And thank you also to CTN for broadcasting for us today. We are here to talk about safe injection sites and overdose prevention with some of the people who have been involved in this conversation on a national and even beyond national level. And as we know, the scourge and epidemic of opioid use disorder, of opioid deaths, continues to plague us. And Senator Anwar has been a tremendous leader, along with some of his wonderful interns who he works with. And of course, those around the state who have continued to help us address this issue. I know we have partners here from the Department of Public Health and I believe Department of Mental Health and Addiction Services and others. And I'm just pleased to be able to be here to listen in. And again, want to thank Senator Anwar for all that he does and continues to do. We are both deeply committed to this issue. And with that, I'm going to turn it over to Senator Anwar.
Thank you so much, Madam Co-Chair. Thank you for your leadership. So by the end of the day today, 4 people in our state on average are going to pass away, unintended overdose. Majority of them are going to be from fentanyl. And that's just the ones who have died. And that does not include individuals who are going to get skin infections, complexities, complications, injuries, and other problems that they will experience because of this. And the Public Health Committee in the last many years, we have made it a priority to start to look at what are the various things we can do to try and prevent all the injuries and deaths that are associated with the substance use related deaths and complications. And thankfully, because of some of the policies, we have been able to improve things in some respects, but not to the level that we can say that this has been fully successful and the job is done. There's a lot more that can be done. And in 2023, we had Senate Bill 9, which passed with overwhelming support. One of the parts of Senate Bill 9 in 2023 was about harm reduction centers in Connecticut. The bill had to change a few times towards the end. And the reason, first, as we had the conversation about this bill, a number of people came out to speak. And it was very important for the general public and every legislator to listen to the experience of the people who were impacted by substances. And as we learned about their experiences and the opportunities for their survival or the survival of their loved ones, it was very clear that there's opportunity to do better. There's opportunity to improve things. And then I think that's where we started to talk about how can we have overdose prevention centers. And when we talk about overdose prevention centers, it's not like a brilliant idea that a legislator came up with. It's something that's been happening for a long time. And hopefully we'll have a conversation specifically about this today. And the reason we wanted to have the conversation about this is that you may, during the course of our conversation today, hear the misinformation about this that is out there in the community, but also learn from data what the reality around this aspect is. And if we are trying to save lives, we have to have an opportunity to look at what experience we can learn from others. So, and then despite the federal laws, there are states in the United States that have actually recognized that they have a primary responsibility to save their citizens. So today we are going to have 2 panel conversations. And then the 2 panel conversations are going to include, the first one is focused on the navigating the legal pathways of overdose prevention centers despite federal laws and what we can learn from the lessons from other states. We have a dream team of people who are going to be able to speak to these important topics today, the 2 panels. And we will, I will introduce one speaker at a time, and then we'll learn from them about the work that they're doing. My first person who's going to be in the first panel, the speaker, is Liz Evans. She's the founder of the Vancouver Harm Reduction Center and is part of the Liberation Program Bridgeport. Liz Evans is referred to as a rock star in the harm reduction world. She is one of the most well-known, recognized, respected individual with 30 plus years of experience. She founded North America's first legally sanctioned supervised injection site in Vancouver, Canada. And she's also serving as the Senior Director of Harm Reduction at Liberation Programs in Connecticut. I just want to say that whenever you have an opportunity to listen and learn from Liz Evans, she's an institution within herself for anyone who's willing to learn about this aspect and see how much of a difference one can make. So with that, Liz Evans.
Well, thank you very much. That's no hard to meet that expectation. But I want to thank you so much, Senator Anwar, for hosting this informational session and for your leadership on this issue. I also want to express my gratitude to the Public Health Committee for being part of this conversation and most importantly for caring enough to be here. And thank you so much to each of you for your public service. It's always inspiring to see people come together around an issue that I care so deeply about, and many of us do. And my hope is that we'll be able to shift policy as a result. While this conversation may seem rooted in legislative reform, particularly in how overdose prevention sites fit within our existing legal framework, I want to first acknowledge that there's people in this room who understand legal resources and nuances better than I do. And there are some people who here who have experienced the unspeakable pain of losing a loved one to an overdose. Your courage and resolve in fighting towards these changes are powerful, and I want to honor that. I've had a lot of different experiences operating prevention centers in many different forms, and I've learned that these sites are not just about the law. They're about people, and they're about the value that we place on the lives of people who use drugs in our community. There is really no controversy about whether or not supervised injection sites or overdose prevention centers prevent death. None of the sites around the globe, some of which have been operating for over 40 years, have never recorded one single fatal overdose. At the site I was involved in setting up over 20 years ago now in Canada, over 4 million injections have taken place there. Thousands of overdoses have been reversed, and not a single life has been lost. The evidence is very clear, and yet here in the US, we're often hearing that we need somehow more evidence. But I believe what we really need fundamentally is a shift in our mindset. We need to change how we view drugs, addiction, and the people who struggle. Because the war on drugs has caused immense harm and has ended up characterizing those who struggle with substance use as criminals, people who somehow lack moral fiber to stop using. Efforts to help them are often labeled as enabling, but this, in my view, is dangerous and misguided. We have allowed people with substance use disorder to be viewed as fundamentally different somehow from the rest of us, somehow worse, but they're not. As Jarrett Zeigan, a researcher, writes, the war on drugs is a war against people, and this war has impacted every aspect of our society. By turning a blind eye to people who use drugs, we're making a fundamental mistake, and it's one I personally came to understand early in my career as a young nurse, confronted with the overwhelming shame and stigma that was faced by people struggling with addiction. My experience since across multiple jurisdictions has shown me that overdose prevention centers exist in many forms, but they are part of a solution. In many places, I've seen these sites operate outside of legal frameworks, but the challenge was to navigate hurdles and to get them through the eye of the needle, so to speak, by educating communities, mobilizing resources, and demonstrating the undeniable value of these sites as public health alternatives. When there is a political will and when communities come together to demand change, I believe these programs can and do happen. And in my experience, fewer people die. Overdose prevention centers work for those who are most marginalized. They attract and retain people into care. In New York, I was involved in leading an organization called On Point, which expanded services like monitored bathrooms where people could use drugs safely. And we invited Dr. Sanjay Gupta from CNN to come and tell this story. And he agreed that these interventions made sense. And as a result of that CNN piece, the sky didn't fall. It was seen as logical. Overdose prevention sites are not just about drug use. They sometimes are adjacent to spaces where people can have access to a bathroom, a shower, a place to do laundry, somewhere to charge their cell phones, and just to connect with others. They offer dignity and humanity in a world that so often strips it away from people who are vulnerable. So I believe what it comes down to is if there is a political will and the community is mobilized, these programs can and will succeed. Our communities need solutions that work, not just to get people off the streets, but to create healthier and safer communities for all of us. I believe that we have the tools and our resources to think about a Connecticut solution, and I believe overdose prevention sites work, and that we should come together to figure out how to make them work here. If we don't move forward, I believe we're allowing preventable deaths to continue, but if we do, we will save lives, reduce stigma, and build stronger and more compassionate communities. Thanks.
Thank you so much. And we'll have some questions and answers in a little bit too. So thank you so much, Ms. Evans. Our next speaker is Livia Cox from the Yale School of Public Health. She's a master's student there. She's also the executive director of the Middletown Harm Reduction Initiative, a nonprofit she co-founded in response to the devastating impact of the opioid epidemic. She's also serving as the EMT in the Middlesex County for the past 6 years. Livia has seen the effects of the crisis firsthand. She has conducted field work on the experiences of female drug users in Vietnam and has worked in overdose prevention centers in northern Portugal. She's also a recovery coach at Yale, serves in the Middletown Opioid Task Force, and also is a former Thomas J. Watson Fellow. She's a vocal advocate for the implementation of evidence-based overdose response policies, both domestically and internationally. Livia has probably done more in just in School of Public Health than sometimes people do in their lifetime. So just so looking forward to your thoughts, Livia. Thank you.
Thank you. Thank you all for being here. Thank you to those of you who are watching. Thank you everyone for your service. So before I begin, just bear with me. I'd like to invite you to close your eyes for a moment, if you can safely do so. And picture what I'm going to describe. So you step into a building, the air is fresh and clean, and everything feels organized and calm. Around you, staff members, be they nurses or counselors, are greeting patients with a smile. They check you in. You're directed to your first destination. For some, that is the consumption room, which is a space lined with sterile equipment, fentanyl and xylazine testing strips, where trained medical professionals are closely monitoring participants with naloxone at the ready. And for others, the first stop is a shower or to the dining room for the first hot meal in a week. Others might go to an in-house clinic for hepatitis C and HIV testing. Others first go to the drop-in center for peer counseling, psychiatry, social services. And as Liz Evans so perfectly alluded to, there is such a palpable sense of humanity in this space. So you can open your eyes if you've kept them closed. So that place I just described is far from a figment of my imagination. It's an amalgamation of real overdose prevention centers that I had the privilege of working at during my time in northern Portugal as a Thomas J. Watson Fellow studying the intersections of pain and policy. And these are places where dignity is preserved, where medical professionals are monitoring people with compassion, and these are places where lives are saved. Back in 2001, Portugal made a relatively bold choice at the time. They decriminalized the use of all drugs. They didn't legalize them, but they recognized that addiction is a public health issue, not a criminal one. They built a system that was focused on harm reduction and support. Outreach teams took to the streets. Homeless centers for drug users were established. Methadone programs, walk-in centers, overdose prevention centers were rolled out. And the results are undeniable. In the past 20 years, Portugal has managed to cut drug-related deaths by 80% and reduce HIV and AIDS and hepatitis infections by half. Meanwhile, during that same period, drug-related deaths in the United States have skyrocketed by over 500%. Despite this alarming increase, a federal law, commonly known as the Crack House Statute, continues to stand in the way of implementing solutions like overdose prevention centers. And I think from the image I described, that is far from what you might imagine a quote unquote crack house to be, which in itself is a problematic term. And this law is rooted in outdated fears rather than modern evidence, and it's obstructing a very proven strategy to address one of the most urgent public health crises that we face today. And here's the most important thing, as Liz said, no one anywhere in the world has ever died in one of these centers, not one person, as a cause of overdose. These centers are not about enabling drug use. They are about preventing death. They are places where people can take their first steps towards recovery rather than their last steps on earth. These centers are driven by data, they're driven by evidence, and they're driven by compassion. We know that stigma and misunderstanding have delayed our progress. But today we have the opportunity to talk about pushing past that, to let data, evidence, statistics take precedence over outdated ideas. If we truly want to save lives, if we want to make sure that people are offered a second chance rather than a death sentence, we must act. We have the tools, we have the knowledge, and most importantly, we have the moral responsibility to do so. What's being proposed here is not radical, as we're showing. It's common sense. It's what works. And if we're serious about addressing the crisis, we need to act just as Portugal has done, as Canada has done, as numerous other countries have done, and numerous others are preparing to do. Thank you.
Thank you so much. Thank you. Our next speaker is Thaddeus Wenson, who is an overdose survivor outreach program member and is at MedStar Georgetown University Hospital. He is joining us from Washington, D.C. today. He's a chiropractor and harm reduction advocate. He works closely with overdose survivors, providing them with support and resources for recovery. Dr. Weinzen integrates holistic and traditional medical practices, focusing on long-term health and well-being of individuals struggling with substance use disorder. And his work emphasizes compassionate care and outreach to some of the most vulnerable communities. So with that, Dr. Weinstein, you're on.
Thank you, Senator Anwar. I'm not a doctor, not yet, at least. But I do work in the medical field here at Georgetown University Hospital, MedStar Georgetown. I'm a certified addiction counselor, the Overdose Survivor Outreach Program Coordinator here at Georgetown. I recently finished a Master's of Science in Addiction Policy and Practice through Georgetown in 2024 under the tutelage of Director Regina LaBelle, who's a Connecticut native. Before that, though, I got sober in 2016 after 16 years of opiate addiction. I'm a walking, talking statistic of the opioid epidemic. Pills turned to heroin and homelessness, IV heroin use, losing connection with my loved ones. I had many overdoses, waking up with rug burn on my face or crumpled in a bathroom or in the ER with withdrawals and seizures multiple times. I mention that because we've come a long way nationwide with harm reduction since 2016. And with all of these policy changes in the past 10 years, there's progress, but we have failed to move the needle significantly on overdose deaths. Had an overdose prevention center been operating in 2008, perhaps my path could have been different. What I see today is people coming to the ER overdosed, and then again, several hours later, if they're lucky enough to make it back here after a return to use, going over the top after, with the naloxone actively in their brain, with going over the top with fentanyl. The fact is, there's a handful of controversial policies remaining that haven't been implemented or tested. Among them are overdose prevention centers, end-use advanced technology drug checking equipment with electron spectrometers, and contingency management, paying us small amounts of money, usually in a lottery setting, for continuous periods of verified abstinence. Some states like New York have been implementing overdose prevention centers despite the federal crackhouse statute that prohibit them nationwide. Other states like New Hampshire and Minnesota now have laws on the books paving the road for these facilities to exist in their state as long as the federal government doesn't stand in the way. Furthermore, there are efforts underway in Vermont, Seattle, Washington, Philadelphia, Pennsylvania, and others to bring these initiatives to fruition. With Connecticut joining the conversation, what I see is a building coalition. If enough states are able to put laws on the books allowing for overdose prevention centers, there's collective bargaining power with the federal government. From a public health perspective, we know that syringe service programs reduce harm, disease transmission, and hospital admissions for issues like wound care, yet we're not better off, much better off than we were in the 1980s during the HIV epidemic, where these services were completely illegal. We face the same challenges as slow progress with overdose prevention centers for a number of reasons, federal law being the major roadblock. If Connecticut is brave enough to join this public health initiative and other states follow suit, state attorneys general could petition the U.S. Department of Justice for a public health exception to the crack house statute, or to strike the statute altogether and reformulate our nation's drug policy. Adapting to a rapidly changing environment in the era of fentanyl, the fourth wave of the opioid epidemic, must occur quickly. I believe that Connecticut having this conversation right now is the progress we need, and I personally thank you for having it. I can tell you that had overdose prevention centers existed when I was using drugs, my former drug using self would have engaged with them. I can tell you with certainty that engaging with healthcare providers who demonstrate compassion and understanding would have alleviated some of the shame and stigma that I was buried under during my active addiction. Having resources at my fingertips and a relationship with healthcare providers could have altered my trajectory with substance use disorder. This is a service that the patients I see every day in the hospital could greatly benefit from, if only it were allowed. I hope that one day soon, DC, Virginia, and Maryland will join the conversation as well. I'd like to thank all of you for your time and for hosting this important conversation, and to Senator Anwar for asking me to join. Thank you.
Thank you so much for your presentation. And the next person on our panel is Professor Scott Burris. He's a professor of law at Temple University, Beasley School of Law, where he directs the Center for Public Health Law Research. He has dedicated his career to examining how law influences public health and has been a leader in advocating for legal frameworks that support harm reduction strategies. Professor Burris has authored over 200 publications and has been involved in groundbreaking research that addresses the legal challenges to overdose prevention centers. So, Professor Burris, thank you for joining us. You're welcome.
Well, thank you, everybody, for participating in this, and thank you, senators, for hosting this. This is obviously really important. I want to say, having listened to several presentations, that the first and most important legal point to make is never concede that safe injection sites by any name are illegal. That is a matter of opinion. We have two cases that have addressed it by two different judges, both from the Philadelphia case. The district court reasoned that the Controlled Substances Act was never intended to prohibit public health interventions that are supported by strong and longstanding evidence of therapeutic and preventive validity. This was then appealed to the Third Circuit Appeals Court, which, in an even longer opinion, decided that the Controlled Substances Act was essentially intended to prevent anything involving the use of drugs outside of strict medical practice. I think the Third Circuit is wrong and the district court is correct, but the really important point for Connecticut, well, there are really two important points for Connecticut when it comes to the law here. The first is that those laws, those decisions, neither of them are binding upon the courts in Connecticut and the Second Circuit federal system. So we still have a kind of blank legal slate with two different persuasive options to draw upon. Second, it's really important to understand the degree to which this is a political question. You've all watched the Supreme Court, so it's not going to be a surprise that political views and social views influence the decisions that judges make. I characterize the decision of the Third Circuit that found that safe injection sites would be illegal to be sort of a typical instance of the, if it's good for drug users, it must be illegal sort of reasoning. The district court's opinion offers many very sound arguments as to why they might be legal. And if Connecticut were to enact a statute like Rhode Island, it would be in an even stronger legal position. And you can read my articles for the details, but essentially, there is a provision in the Controlled Substances Act that explicitly says that courts interpreting challenges to state laws as being in conflict with the Controlled Substances Act should only overrule the state law if the state law and the federal law are simply incompatible. And you have to have a very strong war on drugs, helping drug users violates the war on drugs attitude to think that the operation of a safe injection site or the authorization of a safe injection site fundamentally is incompatible with the Controlled Substances Act. It's no more incompatible than needle exchange. It's no more incompatible than medical marijuana. There are very good arguments. So my sort of legal message is be brave. You have a strong position that your lawyers will be able to ably and we hope persuasively defend in court. Now, the other thing that comes out of the Philadelphia experience is that because this is political and because this is really an intervention that affects a lot of different communities, including the communities where a safe injection site would operate, it is really important as a matter of legal strategy, not to mention a moral imperative, to work with everybody who's going to be affected by this. And that includes working very early on with communities of people who are not drug users, but are living in drug scenes or are affected by public drug use, because they're going to have very strong opinions about drug use and drug use in public. And they're going to need to be convinced that a safe injection site is not only good for drug users, but it's responsive to their needs as well. So working on this as a political matter, both in the sense of developing a strong political pitch for the law and in building a broad base of support for the activity in all affected communities will be really important to the legal fight, because it will set the context. A community, a state that strongly supports this at all levels is going to be in a stronger legal position than a state that's driven by internal divisions, as I'm afraid we were in Philadelphia. So that's really all I have to say, although I can talk about the legal details or send you resources for that anytime.
Thank you so much. And we will have some questions about that in a second. We have a fifth panelist who is part of the second panel, but we felt it was worthy to have Dr. Robert Heimer, professor of epidemiology and pharmacology, weigh in around here, because if we were to go back in time, a similar conversation was probably happening here about needle exchange. And people were having arguments back and forth, and now it's not even an issue. It's not even a question. It's like something that had happened, but it took some leadership, literature, research, evidence-based perspective, and we are very fortunate that Dr. Robert Heimer is here. His research focuses on the negative health outcomes of injection drug use, including overdose prevention and the spread of infectious diseases like HIV and hepatitis. Dr. Heimer has been instrumental in advancing harm reduction strategies through his work on syringe exchange programs and overdose resuscitation techniques across the globe. He's a member of Yale Center for Interdisciplinary Research on AIDS. So welcome, Dr. Heimer. Thank you for coming in despite your very busy schedule today. Thank you.
Thank you. Thank you, Senator Anwar. Thank you, Representative McCarthy, for inviting me to talk today. We'll eschew history for a while. We'll talk the news yesterday that opioid overdose deaths around the country have declined dramatically. And that is true in Connecticut as well. Looking at the data very quickly yesterday, I concluded that since the peak year of 2021, there's been a 25% reduction in opioid overdose deaths in the state. This is not because of drug interdiction. This is not even because of increases in opioid treatment programs, because their numbers have been flat for 5 years or so. This is because of harm reduction. Naloxone saturation and getting out the message of not using alone has led to a decrease in fatal overdoses of at least 10% in private residences. This means that there remains a huge disparity between the people who use their drugs in private residences and the people who aren't. And the people who aren't using it in private residences are the people in urban centers and oftentimes the people in minority groups who are disproportionately impacted by, they're not benefiting as much from the benefits of the decrease in opioid overdoses in the state. That's why safe injection, safe consumption spaces, harm reduction centers are absolutely necessary to reduce this disparity, first of all. Second of all, in addition to providing overdose prevention, harm reduction centers, and of course, Liz Evans can speak to this much better than I can, have a wide range of benefits. She alluded to them. Olivia Cox alluded to them, but clearly just the decrease in the public presentation of drug use as a visible urban problem will make everyone in those communities feel safer. So the benefits for the communities in which we anticipate such harm reduction centers being established are going to be benefits for the individuals who are using those centers, benefits for their family and friends who will not see their friends and relatives die, decrease in public consumption, safer environments, and all in all, the benefits so far outweigh any kind of negative consequences that the fact that we haven't done it is almost inconceivable.
Thank you so much. So this is where the questions of our conversation come up. I wanted to start with Professor Burris about the various arguments that are the legal arguments, because can you explore further? We were discussing earlier about ADA being an argument and the purpose being an argument. How does one navigate the legalities, but also can we make sure that if a bill is to be proposed at any point, can we even be preemptively ready to make sure that there's no challenge around the federal law, how it has been interpreted in public?
Well, first of all, the best preemption to a challenge is political. We saw this in the history of needle exchange. When the legality of needle exchange was questionable, one of the ways you could go forward, as we did in Philadelphia, is to get the group or the part of government that believed it was legal to proceed with it, and to work with the prosecutors in the community to make sure that, and the police to make sure that they didn't arrest people and or bring legal cases. So negotiation, the kind of stuff you guys know best how to do as politicians, is primary prevention. Now, secondary prevention, assuming that you absolutely want to be ready with a statute that is as strong as possible in the courts, is kind of complicated, and I and other lawyers will help you with this. But in brief, first of all, it's very important to stress that this is an exercise of state authority in health. All the kind of recitals are important to make it that you are regulating, you are doing some work in the health space, which is core power of the state. And that's important because of this idea that the Controlled Substances Act is not generally preemptive. The Controlled Substances Act exhibits shared authority over the subject matter with states. So you want to stress that this is state police power being exercised. Your allusion to disability is also important. I think one can write the statute in a way that stresses that we are dealing with a behavioral health condition that is protected by disability law from discrimination. That's a nice thing to suggest. I think another thing to emphasize throughout is that this is a legitimate public health intervention, because the idea in the Controlled Substances Act is it's trying to distinguish between illicit and legitimate medical uses of medication. One can also write these statutes to further isolate the Controlled Substances Act in the sense that there is no controlled substances prohibited sale or distribution of drugs going on in these settings. So there's no argument this is somehow promoting that kind of illegal activity. And then finally, of course, as always, stressing the benefits to the communities and to public order and to indeed to law enforcement and the reduction of crime. All these things are ways that we can prepare the way in writing the statute so that if it is challenged by the feds one way or another, to increase the chances of winning in court. The other thing that we certainly was clear in Philadelphia and has been true from the needle exchange experience is if politically or otherwise one can be in a posture in which instead of the government the feds preventing the opening or challenging the idea of the safe injection site, they are actually trying to shut down a site that is already saving lives. It's just much better to be protecting an open site in the courts and making the court have to shut down something that's saving lives versus doing it in the abstract, where we're just asking whether in principle such an enterprise is legal or illegal.
Thank you so much. Do any of the other panelists want to weigh in on the same question? You're welcome to do so. Go ahead, Liz.
I just wanted to ask a question, actually. I don't know. I mean, in Canada, when we were able to open legally the first site in 2003, we opened under what was called a research exemption as a pilot. And because we had support from the local, municipal, provincial, and federal government to do that, no laws had to change for that pilot to operate. It was just a carve out from existing Controlled Substances Act. So I don't know if such a mechanism exists here, but it seems to me that
such a mechanism exists in the Controlled Substances Act, but it begs the question of the federal position. So it would require the Attorney General and I believe the Secretary of HHS to sign off on this, and that seems highly unlikely to occur. If we compare SIFs to the medical marijuana case, one of the things we might reasonably hope for is that, as in medical marijuana, the Justice Department issues a non-prosecution memorandum to its district attorneys, its U.S. attorneys in the states, under which it says, well, we still think medical marijuana is illegal, but we have bigger fish to fry. It's not hurting the public that much, so don't bring those cases. That was mooted, I believe, in the Biden administration, but never quite happened. But it's still something that perhaps in a future administration could occur. But I don't think we'll get a research exemption because that would require positive approval. Now, nothing, of course, stops anybody from lobbying senators and congressmen in Washington to change the crack house statute and to make clear that it does not cover bona fide public health interventions in the same way that many years ago Connecticut changed its law to make clear that syringe exchange was legal.
I would just like to sort of fully support what your comment was about the political will and the community political will, because certainly in my experience, even prior to laws changing and working in New York, educating prosecutors and working with the community groups and in the media to advertise and talk about the need for an intervention like an overdose prevention site, insulated, I believe, to a huge extent, the conditions there that have allowed it to operate. And that work was essential in terms of getting people on board. And as you all know, no laws have changed federally, and one is operating and has been now for a while. So I think our efforts need to be layered with a big piece, speaking to local people in Connecticut about the reality and removing any fear from this notion that an overdose prevention site is nothing other than a public health intervention that is addressing a very practical problem in a very practical way. And one of the things I really like about this term harm reduction is agnostic is I feel that it addresses some of these issues that underlie some of the controversy around these things. And that is that people often misinterpret efforts made to keep people alive who are using drugs as somehow celebrating drug use. And I always think it's super key to say that harm reduction is not saying, oh, yay, you're using drugs. It's to say it is happening and it's a reality and it's agnostic. It's not value-based, but it's not denying that reality and it's not pretending that it's not happening, which is really what all our alternative policies are doing, is saying that somehow if we knee jerk to these other kinds of laws that have been criminalizing people, that somehow that's going to have a net positive effect. And as Dr. Heimer pointed out, the decrease in overdose deaths in our state has nothing to do with people being arrested.
Thank you for that. Representative Kristen McCarthy, he has a comment or question.
Thank you, Senator Anwar. And just to follow up, Liz, on what you're saying, less judgment, more solutions, more saving lives is I think part of what you're saying. So Attorney Burris, I think I just want to clarify if I'm hearing what you're saying correctly, which is that you're challenging us as a legislature and as a state, because of course it would need the support and the signature of the governor to be able to go into law, to basically make this happen. And then from a legal standpoint, it would be a stronger and better position, and that there would be, you know, support and people who would be able to rally around that. And certainly we'd have to talk about that here in our own state. But part of my question is, in Philadelphia, with that legal challenge, what kind of involvement did you have from the judicial branch of government there?
Well, so from what happened in Philadelphia was that a panel of stakeholders that the mayor had convened to look at our opioid crisis. And keep in mind that Philadelphia has one of the worst drug scenes the world has ever seen. The Kensington drug scene is a magnet for people, and it's also, the ultimate dead end. We've had, a couple of thousand people die in Kensington, and we still have pretty much the same number of people there. So you understand that people are coming there at the end of their drug using journey. And it's a huge challenge for a city to deal with, even just having the resources to deal with a scene of that size. And so I want to emphasize it's not an easy problem. A few years ago, the mayor convened a panel to look comprehensively at this, and one of the subgroups recommended that we operate, I think we called it a comprehensive user engagement site that would provide services, including safe injection services to the people in Kensington. The mayor sort of picked this up. So in the end, the commission that he had established agreed with the recommendation, but didn't exactly adopt it. And then the mayor recruited a group of civic leaders, including the heads of our AIDS Law Project and our former mayor, Ed Rendell, to start a foundation to run this as kind of a private operation. I personally think that was a big mistake, because it signaled limited political support. And from a legal point of view, it meant that this was not a government agency or a government unit of government exercising its police power to protect public health. It was a bunch of people who thought they ought to start a harm reduction program, starting that program. That weakness cascaded initially in a lack of a political deal with the local U.S. attorney. That was probably impossible because it was a Republican administration and the U.S. attorney was gunning for this. And the U.S. attorney quite cleverly filed a declaratory judgment action. So a prospective action saying that there was now the possibility of such a site being opened, and he wanted the courts to invalidate it. miraculously, the case was assigned randomly to a judge in the Eastern District of Pennsylvania who had an open mind on drug law and who looked at very comprehensively at the many problems in strict legal interpretation that arise when you try and apply the crack house statute to something like a safe injection site, and ultimately delivered a very powerful opinion allowing the site to proceed. By that time, however, the organizers were beginning to feel the pain of a lack of community support and I think an insufficiently effective approach to community engagement in Kensington. So they weren't able to proceed with that district court opinion because they couldn't get political approval for any sites. And then as time passed, the case went up on appeal and went to a much more conservative judge, as I've said, and the Court of Appeals ruled that that a safe injection site was illegal. That is, of course, binding law in Pennsylvania, New Jersey, and Delaware. So that has largely ended the chances of a safe injection site in Philadelphia.
Thank you. That was an extremely helpful answer as someone who grew up outside Philadelphia and knows a little bit about some of the people you're talking about. Helpful both from a legal standpoint, but also political, because Mr. Rendell is someone who has tremendous political influence, even being out of office. And it speaks to the challenge that is faced to overcome the concern. And I certainly, I'll name that, as Liz was talking about it. I was thinking from my former planning and development committee chair hat and thinking about zoning and siting. And even in my own local community, the objections that have been voiced about a daycare center being sited in a certain location. So the challenges are real, but it's helpful what you've described. And I certainly would say that the political environment at the federal level certainly has a tremendous impact on our ability to have these conversations and for them to be successful. I'm certainly cognizant of that as we approach the election, but thank you very much for the answer. Thank you, Mr. Chair.
Thank you. The next person is Dita Bhagrava, who has a question, followed by Representative Tracy Mara.
My question is for Attorney Burns. I just wanted to revisit sort of the conversation around the political climate federally on harm reduction issues. And you had mentioned that you didn't think that the Secretary of HHS and the Attorney General would be willing to interpret the drug control laws favorably for harm reduction. So I'm just wondering why you think that is. And I don't think we touched on this yet. We've spoken a lot about Philadelphia. I just wanted your opinion about Oregon and the decriminalization of small amounts of drugs there in 2020, because that is a conversation that comes up many times about quote unquote the failure of that notion, which I understand that it was clearly not implemented fairly or properly. But if you have any knowledge on this, just so we can mitigate any misconceptions if and when we are trying to pass laws in Connecticut, that would be very helpful.
Sure. Well, I mean, my views, of course, are consistent with those of Ms. Evans and Dr. Heimer. We always have to ask when we look at reform in drug policy, compared to what? We have a very toxic current system that causes a lot of deaths, and then we have efforts to try and do something new. But just getting rid of the Controlled Substances Act, just offering service, it doesn't really get you where you need to go, because you have to have the kinds of services represented by safe injection sites available, so that when people are using drugs, they're not dying. I will say that there is some research, the most recent research from drug policy analysts, is that the liberalization of drug possession law in Oregon was not the cause of the rise in overdose deaths. That had to do with the entry of fentanyl into that market at the same time. which was a sorry coincidence. And I think the evidence is pretty good on that. In any event, it is drug policy reform is a long-term effort, and you have to make the initial change away from just putting people in jail, and then you have to figure out how do you make the new system work. So sorry about that. It was a little bit long, but basically, no, it's spurious to suggest that Oregon's reform caused more death. I'm sorry, what was your first question?
The first question had to do with, I think, your comment on HHS secretary.
Right.
And also, I think it was HHS secretary and the attorney general in terms of interpreting the drug control laws favorably. You didn't think that would happen. I'm just wondering why you think that is.
Well, maybe I should say that I'm making a historical judgment since I'm not a political expert. There have been almost no instances in which the research exemption that Ms. Evans referred to triggering has been triggered. So Dr. Heimer knows that there was strong evidence that heroin replacement therapy, or that using hydromorphone could be an improvement over methadone treatment for some patients. There was lots of international evidence, and there's been a hope to try that in the US, but it's just really difficult to get approval for that over many years. Similarly, we never had medical marijuana research because people couldn't get that research exemption. So it just seems to be very hard to get that to be triggered under any circumstances. The second thing is a broader point, which is, but worth keeping in mind, and that is that it is a lot easier to get people to ignore something than to endorse something from the legal regulatory point of view. So if what we're asking the Justice Department to do is pay attention to other problems, that's happened. It happened with medical marijuana. I think it could happen here. It maybe almost did happen here. That's very different from getting them to say, oh, yes, we think this should go forward. So that's basically what we're talking about here.
So better
Don't put them on the spot.
Better to ask for forgiveness than permission. I guess.
Yes.
All right. Thank you. Representative Mara.
Thank you so much. Thank you, Senator Anwar, for getting this together. It's very interesting that the previous question said better to ask for forgiveness, because I literally had that written down on my paper as well. And it sounded like exactly what Attorney Burris, you were kind of alluding to, which is maybe not really where I'd like to go with something like this. I am a big proponent of thinking outside of the box when it comes to, dealing with our overdoses. So I guess, and I know when we looked at like the On Point in New York City, and it is very much, in those centers, it is a harm reduction unit coming to the space where harm is happening, which I think is, ideally, and I believe what, our local harm reduction units are thinking of too. But I guess I'm kind of curious as to your thoughts of it. It sounded like there was almost like a trigger law kind of aspect to what New Hampshire was doing. I think you mentioned like 2 or 3 other states that kind of said, well, it's on the books, and as long as we find out the federal government is not going to mess with us, we'll move forward. Could you talk a little bit more about how something like that would work, and whether you see like a multi-state pack with something like that?
Well, I mean, that's a great sort of political analysis of this. The more states that do it, as with medical marijuana, the harder it becomes for the feds to challenge it as a political matter, right? So yes, it'd be great if more states do it. Secondly, the fundamental legal position we're taking is not that the Senate, the legislature in Connecticut or New Hampshire can do something illegal. You can't violate federal law. It's against your responsibility as legislators. Your responsibility is to follow the law. The point here, though, is that it's not clear that the law prohibits safe injection sites. There are very reasonable arguments on both sides, and there are court decisions that go both ways. So at that point, you could say, well, we take the position. We've thought about it. We've consulted our legal advisors. We think it's legal. We think we have the authority as a state to do this. The feds may or may not disagree. And if they disagree, they may or may not take action based on the disagreement. As Senator Anwar suggested, it's best to write the statute with as much foresight as possible in the event of a challenge. And it's probably realistic to assume that that there's going to be a cost for the state to defend this if it's challenged. But the history of needle exchange was exactly the same. People did it based on the belief that they had to and that it was legal. And they did it all over the country, and states rapidly came on board. And most of the time, they weren't challenged. And in Philadelphia today, we are 25 years into the operation of what we regard as a legal needle exchange authorized by the city. We have never changed the state law that some people think makes needle exchange illegal. Yet we also have needle exchange now going on 20 years in Pittsburgh. And the reason that persists is that no one has undertaken to challenge that legal view. And that's what we'd like to have happen here. The feds have their views on safe injection sites. States have their views. States move forward on their reasonable views. And we hope that, leaving aside Philadelphia and its unique politics and its poor legal starting point, we'll never have it challenged. And if you think of it any other way, you don't do anything. If you wait for validation and clarification of the law from the feds, law that may not even prohibit safe injection sites in the first place, you'll never get it. I mean, in terms of the life expectancy of this crisis, you might as well just go home. It's act or nothing.
And if I can just follow up a little bit, please, how exactly is New Hampshire's law? You mentioned that they have something on the books and they're kind of waiting to see if they get something from the federal government. And were there 2 other states as well? And what exactly did they put on the law, and how are they waiting?
Well, actually, I'm not intimately familiar with New Hampshire's law at this point. We have Rhode Island, which is proceeding but slowly. We have New York, which is proceeding by a kind of minimal authorization, and with a political deal, I guess, with the local U.S. attorney. I mean, there hasn't been action. We had Philadelphia, which had no law. So the strongest legal position is that you pass a law as a state, exercising your police power to address this health issue. If you do that, there's no point in putting in but we'll wait to see if the feds say something different. Because this is a federalism issue. The fundamental fight we're having in terms of governance is, aren't states empowered to deal with their health crises the way they think best, consistent with their state's law? And what are the feds doing, telling us in the name of drug control that we can't have public health prevention activities proceeding among drug users? We're not doing anything illegal. We don't have to wait. So in that sense, the New Hampshire approach is kind of flawed, and it amounts to a sort of legislative failure of both of courage and, I think, logic. They do not have to wait for the feds to agree.
Okay, thank you so much. Appreciate it.
Thank you. This is actually a great segue for our second panel, and then we'll have a more robust conversation after the second panel because we're getting warmed up right now. With that, the second panel that we are talking about harm reduction landscape in Connecticut and opportunities for moving forward. Our first speaker is Deeta Bhargava with the Yale School of Public Health. She's a parent advocate and a technical panel expert for SAMHSA. Deeta, after losing her son Alec to fentanyl poisoning, has dedicated herself to fighting the opioid epidemic. She's an advisory board member for Shatterproof and has collaborated with Connecticut government officials to launch the Shatterproof Treatment Atlas. She works with the Biden administration's White House challenge to promote Narcan awareness. Her advocacy focuses on reducing the stigma associated with addiction and promoting harm reduction strategies. Deeta is a force of nature for good. It's a blessing to know her. And Deeta, if is on this side and continues to do this, we will have a law in the state of Connecticut as well. Deeta.
Thank you. Thank you, Senator Anwar, for inviting me today, your kind words, and for your continued fight on this and so many issues. And thank you, Representative Vahey as well, and honorable representatives. Thank you all for your time. I'm Dita Bhargava, an ambassador for Shatterproof and board member for Liberation Programs and the United Way of Connecticut. I'm here today to implore you to consider safe injection sites in our state. I am encouraged by the recent public health bills passed in our state around the overdose crisis, including the opening of overdose prevention centers last year. And I want to thank many of you from the bottom of my heart for working so hard on enacting much needed legislation, but we need more. Sadly, despite our state's best efforts, overdose rates continue to be at unacceptable rates. They've declined, but too many people are still dying. The scourge of fentanyl and other deadly illicit substances has turned a crisis into an endemic. We must do everything we can to stem the loss of precious lives in our state. In 2018, my family had to suffer through the devastation of losing a child to addiction disease. Our son, Alec Pelletier, died unwittingly of fentanyl poisoning on his 26th birthday while living in a sober home in Canaan, Connecticut. Alec was a warm, vivacious, athletic AAA hockey player. As a teen, he suffered from a mild bipolar condition and started self-medicating, first with easily available opioids and then with heroin. In the end, Alec wanted nothing more than to live a life of recovery, sobriety, empowered by the love of his family and friends. He wasn't allowed that. And the real tragedy is that my family is far from alone. Over the last several years, we have senselessly lost thousands of young lives like Alec in our state. At our son's services in Sharon, Connecticut, I was told by the funeral home owner that he had hosted 7 other funerals that month of young men who had died of overdose. Why is this pandemic one that we are having such problems controlling? It's because the fentanyl scourge in our country hunts down innocent folks who suffer from substance use disorder before they can find a path to permanent recovery. This was the biggest fear for our son, and it became a living nightmare. Our moral, social, and economic obligation is to find bold solutions to end the deaths. And we must keep people alive long enough to get them on a permanent path to recovery before the deadly substances find them and take them away. This is what safe injection sites in Connecticut will provide. Like me, some of you might make decisions based on data. Well, here are some compelling facts which are difficult to turn away from. The cost of the opioid epidemic to Connecticut is estimated at about $10 billion a year. Imagine the money saved due to avoided ambulance rides, ED visits, hospitalizations, morgues, and instead keeping people alive and working and participating in our communities. OPCs provide a safe place for education, like was mentioned earlier by Liz, by connecting individuals to treatment. They connect people to other types of services, including doctors, social workers, and therapists. OPCs have been 100% effective at preventing overdose deaths. They are cost-effective, reduce syringe litter in local communities, and increase engagement by visitors to treatment. Last year, some of you toured On Point. We talked a lot about On Point today, the OPC in New York City. On Point has been open for over 2 years and intervened successfully in over 1,000 overdoses. In Vancouver, as Liz was talking about, an OPC was established in 2003, where over 5,000 overdoses have been prevented. I had the opportunity to visit the one in Vancouver with Liz and with John Hamilton from Liberation's programs, and my daughter, actually, who stays close to this issue because she misses her older brother. Not a single person has died in any of these centers. It's amazing the work that is being done. Seeing it in person was incredibly moving because I imagined our son, had he had the opportunity to access one of those, he would still be alive today. This past summer, during a visit to Portugal, I had the honor to meet with folks at the Portuguese drug czar offices. As we discussed earlier, Portugal had one of the worst heroin epidemics in the world in the 1990s. Thank you for talking about that. Through a community command approach, they directed scarce public dollars to healthcare, drug treatment, job training, and housing. Healthcare in Portugal is free and easy to navigate. They stopped arresting drug users, and instead of a fine, they gave them the option to attend a meeting conducted by a team of counselors, where many of the users would find help and eventually sobriety. Essentially, Portugal started treating those who are addicted to substances not as a personal and moral failing, but someone who has a health problem. And law enforcement became a bridge to social programs instead of jail. By accepting the reality of drug use rather than eternally hoping it will just disappear, Portuguese shifted from a criminal approach to a public health one. Less stigma, fewer penalties, access to social services, and harm reduction. It is literally as simple as that. We can do this in Connecticut. Now is the time to be bold. We are supported by an understanding federal government. The climate is right for this. The Biden-Harris administration has been committed to harm reduction. Biden's secretary, I know we spoke about the secretary of HHS, but he did tell NPR, he said, quote, "We are literally trying to give users a lifeline." To me, that is affirming that the federal agency is not going to intervene in state efforts to create safe injection facilities. The administration has invested over $83 billion in prevention and treatment, a 42% increase over the last 3.5 years. And it's not coincidental that overdose rates have fallen for the first time in 5 years. In 2019, U.S. prosecutors, as we discussed, sued the nonprofit Safe House in Philadelphia that tried to open up an OPC. The Biden-Harris administration, on the other hand, has been a consequential leader in various aspects of harm reduction. Under their administration, 2 OPCs have opened in New York City. Another one is hopefully on the way in Rhode Island, and most recently in Vermont. And the federal government is committed and supported. I've personally spoken to Vice President Harris, to the head of ONDCP, Dr. Rahul Gupta, and our very own Dr. Delphine Rittman, and they are committed to doing everything possible to turn this endemic around. Honorable Connecticut legislators, I know in my heart of hearts that that night our son left this world on his 26th birthday when he succumbed to that internal voice that convinced him just one last time. If he had had a safe, supervised, non-judgmental place to take that drug, because he was so shameful every time he relapsed, because people told him all his life that this was a choice, that it was his fault, that he would still be here today. He would be here as a son, as a brother, a friend, a husband, maybe even a dad. Too many precious lives gone, too many that will continue to be, unless we save them, until we find that safe space to save them. So please consider this act. The first duty our government has to its people is to keep them safe and keep them alive. Too many precious lives in our state depend on this. Thank you so much for your time and consideration.
Thank you so much, Dita. Thank you. Our next panelist is Benjamin Metcalf, who's the Chief Operating Officer for Root Center for Advanced Recovery. At Recovery, he oversees the strategic and clinical operations of the organization. With over 15 years of experience in behavioral health services, Ben has played a key role in expanding methadone maintenance and outpatient services. He's also an adjunct faculty member at Southern Connecticut State University, specializing in the treatment of co-occurring mental health and substance use disorders. Welcome. Thank you.
Thank you for having me here. I've been working in the field of co-occurring disorders and substance treatment for about 20 years. I'd like to speak about this topic from a clinical lens. In my experience, I've never met anyone that says, when I grow up, I want to be addicted to substances. Those people do not exist. Yet in our broader society, we treat people as if they do. Opioid use disorder is a biochemical organic brain disorder. These drugs alter how our brains function. Once someone starts to use, be it because of an underlying medical condition that required them to start narcotic medications, or someone initially or unwittingly using these substances recreationally, or someone trying to self-medicate an underlying trauma or mental health issue, once it starts, it grabs hold of you rapidly and does not let go with ease. All the things in life that once gave a person pleasure and happiness are gone. Without the substance, people become physically ill. Medical and behavioral health interventions are needed to change the trajectory of this disorder. This is not a moral issue. It's a medical condition. We need to address the stigma that exists around opioid use and recovery. We cannot ignore the fact that this disease impacts all walks of life: rich, poor, black, white, mothers, fathers, siblings, children. This is not a disease that impacts individuals alone. It's a family issue. It's a community issue. It's in our communities now. It's in our neighborhoods, our schools, our homes. Overdose prevention sites create a safe environment for providers and caregivers to meet people where they are at. They allow people and their families to recognize that they are not bad or immoral. They allow people to understand that they are not alone. If we do not acknowledge that people will continue to use in private, regardless of our current efforts, and adopt our practices, we will never be able to fully reduce unnecessary deaths. Narcan access has had a significant impact on the overdose rate, but you cannot use naloxone when you are by yourself. It's not physiologically possible. People die when they are alone. There's so many missed opportunities because we do not have these safe havens for those in need. We cannot help people if they're dead. Folks might not come to these sites seeking help initially, but as my peers have stated, this gives us opportunities to address holistic issues that individuals might not have recognized that they needed to until they arrive. When we treat people humanely, without stigma, people will be more open to seeking help and less afraid to ask for it. It allows us to help people navigate the stages of change and instill hope into individuals. This is not only treating individuals, but our communities. If the fear is that an overdose prevention site will bring a problem to a community, I have to tell you, the problem is already here. Just look at the overdose rates for the past 2 decades. Overdose prevention centers are another tool to help us improve the quality of life for all. If we continue to ignore the research and try to pretend that these issues don't exist, we will never get ahead of the issue. Thank you.
Thank you so much. Our next panelist is John Hamilton. He's a Chief Executive Officer for Liberation Program, Bridgeport, Connecticut. He's nationally recognized as an expert in addiction treatment and has over 3 decades of experience in the field. John Hamilton has served in numerous leadership roles, including as chair of the Connecticut Department of Mental Health and Addiction Services Advisory Board and the Governor's Alcohol and Drug Policy Council. He's a consultant both to NIDA and SAMHSA and has received prestigious AATOD Neiswander Dole Award for his contributions to addiction treatment. Thank you, John, for being here, and thank you for the work that you do. And please go ahead.
Thank you, Senator Anwar. I appreciate you having me, and I am absolutely confident that we can successfully implement safe injection sites here in Connecticut, particularly with the expertise around this room. With Dr. Heimer, Mark Jenkins, Liz Evans, we have the ability to do this. And I understand the Senate Bill 9, there probably was some reservation in the past by Demas. I could probably understand them not wanting to have a misstep and waiting. Looking at what happened in Rhode Island, where 3 years ago they passed the legislation, but they didn't have a provider and they didn't have a location. It's different here in Connecticut. We have providers that are absolutely in support of this, including liberation programs. And I have the support of the city council. We were approached 3 years ago by the city council of Bridgeport, the leadership there, with Jorge Cruz and other members asking us, 3 years ago it was, I pretty much 3 years ago, right, Liz? Liz is nodding, saying, please, can we have a safe injection site here in Bridgeport so we can save some lives? So we have the support of the city. I have the support of my staff. I have the support of those that we serve in outreach and our team. We have the support of our board of directors, as you heard from Dita earlier, who we're very privileged to have on the Liberation Board. And I think the time is right. And finally, I think Rhode Island has, in the last 3 months, opened up safe injections. So the time is right for Connecticut to consider this. I also have the support of my colleagues, as you heard from Ben, sitting next to me from Root. Methadone providers particularly are in support of this safe injection site, and we've actually been doing harm reduction for years. In the methadone space, we will work with individuals regardless of their continued use in other illicit substances, and we'll treat that without judgment and continue to remember why they came in, which is to be able to stabilize their opiate addiction, even if they are using other substances. So we've been doing that for over 20 years. We've also been working in the space of Ryan White. Ryan White Funding is committed to work with individuals living with HIV, regardless of their commitment or involvement or interest at all in their recovery. We will continue to work with them. And we've worked with people in the Ryan White space for 4 years, 5 years, sometimes 10 years when they finally say, okay, now I'm ready to get in recovery. And I feel like that will be the same situation when we're looking at safe injection. I think that the American addiction treatment system is clearly flawed in that it assumes everyone is interested in considering abstinence. You know, there are many pathways to recovery, as they say, but most of them are pressured or lead towards abstinence. And I would like to have us today consider harm reduction as a pathway to recovery. The reality is only 10% of individuals who can benefit from addiction treatment today will actually access addiction treatment. So 9 out of 10 individuals are out there today that could benefit from treatment but have no interest. We're selling a product that nobody really wants to buy. Some of the greatest obstacles, obviously, are stigma and shame. And most seek treatment, honestly, when they finally come in, it's because they're either mandated with a gun to their head or mom-dated, where they have family or the criminal justice putting pressure on them to come in. So they'll come in for treatment, but all we're getting is compliance to try to rest assured their loved ones to not have them worry about them when there's really no internal level of motivation and change. And I think that influences a lot of the work that we need to do to really meet people where they are without our agenda. And I think we're not doing that for the most part, and we can do a better job of that. We know there's evidence that treatment works, and particularly for opiate addiction, it would be methadone and buprenorphine. My colleague, Dr. Heimer, who was here earlier, just released an article on deaths in 2016 and 17 with Gail D'Onofrio and David Feline. And it's a pretty eye-opening study of the deaths in 2016 and 17 in Connecticut and exposure to treatment within the last 6 months. And what it shows is if those individuals were exposed to methadone treatment, it reduced their likelihood to die by 58%. If they were exposed to buprenorphine, it reduced their likelihood to die by 38%, which is great news. But the most disturbing piece that I find that I think we need to look at first, do no harm, that came out of this study, is if those individuals were exposed to a 30-day abstinence-based program, it actually increased their likelihood to die of a lethal overdose. And why is that? For the reasons that Dita had mentioned earlier. A person becomes committed towards compliance to an abstinence-based model. They've reduced their tolerance because they're now in a 30-day abstinence program. So if they relapse, they're going to relapse in shame because they don't want to disappoint their loved ones. It's going to be in their house. There's no one around to administer Narcan, and they're more likely to die. So the solution is public consumption, having an individual to have others around to save their lives, as Liz has been doing for over 20 years. And now we're so blessed to have her a part of the Liberation team to be able to hopefully implement this sooner than later. So harm reduction at the end of the day is about engagement. As Ben says, from a clinical perspective, we talk about these stages of change, meeting people where they are. And it's the pre-contemplative or contemplative stage of change that people used to talk about as being in denial, when the fact is the clinicians were in denial of paying attention to what that person needed. So we really need to meet people where they're at and see this as healthy connection and innovative engagement so we can help save those other 90% of the individuals out there that are not interested in an abstinence-based treatment. There's also this hierarchy of needs. If you ever took a psychology class, there's this Maslow's hierarchy of needs. And at the tip of the iceberg, or the tip of the triangle of this hierarchy of needs, is self-actualization. But the work we do at Liberation is on the lower end of the triangle, which is to have a safe space for people, to look at their safety needs and their basic needs first. And I actually think what we need to do is have an overlay of that hierarchy of needs with what we're calling now in the recovery field recovery capital. And there's a certain threshold, I believe, in recovery capital that an individual needs to be able to be willing and able to even consider abstinence. And I think we should see that we can work together as a continuum, and that we're not in odds with abstinence-based treatment. It's just not everyone's there. In fact, we know less than 10% of people are there. So let's work with building recovery capital. Let's work with meeting people where they are without our agenda, and really treating them with dignity and respect. As was said by Livia Cox earlier, it's all about a safe space. And that's what we want to create, is a safe space. And at Liberation programs, I'd like to think all we do is harm reduction and prevention. On the front end, we're reducing harm in a way that allows the community to know the risks of substance abuse, especially the developing brain, because for women, it's the brain doesn't develop till 24, for men 25, for Mark Jenkins maybe 40, but we're not judging Mark. And we can actually know that we try to push back that age of onset to help with that primary prevention. Our treatment programs are doing harm reduction and reducing the likelihood for relapse prevention, for relapse, by being able to give people self-efficacy, life skills, self-regulation tools, and we're looking at the high-risk situations, people, places, and things that would put them at risk. And then most importantly, our outreach efforts that are doing the work in our vans, in the communities, with the other 9 out of 10 people that aren't interested in treatment, are reducing harm and doing prevention to prevent harm from individuals dying. And by doing that, it is a simple solution of across the continuum. It's more important to show people how much you care before you show them how much you know, and treat them with dignity, respect, and love. Thank you.
Wow. Thank you. So our last panelist. So when we started our first panel, we had a rock star, and as we come to the last panelist, we have another rock star. And that's Mark Jenkins, who's the founder and executive director of Connecticut Harm Reduction Alliance. Mark has service-connected disability as a veteran of the United States Air Force, and for 24 years, he's been actually much longer than that. He's been a harm reduction specialist and working for public health and well-being of our citizens in our state. He has delivered innovative prevention and intervention strategies across Connecticut. He began his career as an AIDS risk reduction outreach worker, and has worked extensively with organizations like the Hispanic Health Council and the AIDS Project Hartford. He's well known for his deep connections within the community, and has been advancing the best practices and support. He's also somebody that as soon as any legislator would have a conversation about harm reduction, the first question is, have you talked to Mark Jenkins? I said, well, how could we not talk to Mark Jenkins? So Mark, you're on.
Senator Anwar, thank you. Senator McCarthy, thank you all for being here and speaking for me. John, the gloves are off. Okay. I can never say no when forums and platforms like this take place, because I am first and foremost a harm reductionist. And it's something that I take seriously. My organization, the Connecticut Harm Reduction Alliance, and forgive me, my voice is a little strained, has from its very onset just been there to meet the basic needs of the people that we serve, and where we see need, we meet it. And that's probably one of the fundamental aspects of harm reduction. And that landscape has changed dramatically over the years. But the work has become a lot more professionalized. And as the environment for harm reduction has been more welcomed. I was actually out part of the 17-member steering committee that helped develop the harm reduction framework for SAMHSA, CDC, and the ONDCP. And we actually have a meeting right after this where I'm facilitating, moderating one panel and speaking on another on this very topic that we're talking about here today. I was also part of the contributing author for the rewriting of the SAMHSA opioid overdose toolkit. So I've been just always kept, abreast of what's going on. But for the most part, letting people know harm reduction is not the, all the negative things that people immediately come to see. I know when I first came to even this circle here in this room, actually, it was very daunting because I was at very best outreach worker, someone who knew what needed to be done and really believed, because I really was vested in my community and how to get that done. Yet there weren't anyone or any organizations that looked like me or did what we really needed to do in our communities. Not to say that people weren't doing work. As Dr. Heimer would have said, a lot of this work came about during the height of the AIDS epidemic. So we've been attuned to epidemics. So doing frontline street engagement just a few blocks from here for almost 30 years now, I think we got to change those numbers, and it just makes me feel old when I think about it. But still, the message still remains that harm reduction, I say is really about radical love. I tell people when I speak, we love everybody. Some people we love to see come, others we love to see go, but we love everybody. Harm reduction says you can try for abstinence or not, but let us keep your life and the lives of those around you safe. And with that mindset, my career in this work to date has been really trying to maneuver an unwelcome landscape for most of my career, and how to move this work and move this dial forward and present it in such a way that it's digestible, that we receive the least amount of pushback. So even like when I walk in today and I hear you saying safe injection sites, I've said this to Liz. I will try to keep my vocabulary as clean as possible. Connecticut is too anally retentive for that to ever happen with that language. It's not going to happen in this circle. And it's not about it. It really comes down to what's digestible, not what's necessary, because you've been, I applaud you being a champion of this work. But until it's not a threat, or those can get over the threat of not being reelected to do what's right, to really respond to public health emergencies, or again, until everybody can point a finger higher up and they said it's okay, we will continue to have these battles and until we can get, movement or be guilted into it. And what I mean by guilted, well, Rhode Island and everybody around us is doing it. And so, we're looking like we're behind, and Connecticut's a leader. We're a leader in this. So, we can't fall behind now. So who's going to do it? Who's going to step out there and see if they don't get reelected first? And forgive me if I'm jaded, but if I can't speak honestly, as from my experience, then I think you probably wouldn't invite me to these circles. You know what I'm saying? And I do this in whatever circle, whether it's to, you know, Raul Gupta, to Miriam, to any of them, whatever room I'm in, Ingvild, Captain Jones. It's important that we are getting this work done. And at the end of the day, I really don't care who gets it done. I want to see it benefiting the communities that need it most, because everyone in this room can agree too many lives have been lost. And as Scott was saying, in Philly, you know, but we have our own Philly here. It's horrible. The way it looks on the street is horrible. And how long can we continue? You know, when you talk about treatment, you know, modems and everything, historically, the definition of insanity in that treatment world is doing the same thing and expecting different results. So like somebody needs to knock on the doors next door and say, hey, we're, you know, this is by very definition insane, because we're not, you know, we've got our head in the sand. When are we going to take our head out of the sand? We have the I mean, you know, we don't have anything that resembles what we should. We're not talking about reinventing the wheel. We're talking about taking some basic, proven work that already exists. The numbers, the statistics for all of this exist. I don't have to sit here and throw numbers at you. All we have to do, you know, we have folk even in this room that are willing to get it done. I see Steve from Desk. He's been doing some great work in New Haven and has support. Like, you know, like it's jealous the amount of support. I get jealous. So I'm like, shit, I don't get that much help, you know? John, Liz, we have people who are ready to do this work. Hell, I can flip a site in two days. I can run to you know what we have this. It's a matter of us saying, you know what, enough is enough. I mean, we as an organization, and I believe in keeping my head low and really just trying to get the work done, because that's at the end of the day where we have to be, and choose my battles. And as a result of that, you know, the partnerships expand. We have now been able to get one of our tools that helps to expand syringe service programs, the Rover, in every methadone clinic in the state. The LMHAs are next. We have them in all types of settings where people are saying, okay, we're willing to take this next level to reach people, because this is about engagement. This is about reaching people. This is about providing something other than a business card to say that we care about you and we want you to keep coming until some other level is right, or you find a healthier relationship with wherever you are in your journey, and that there is no cookie cutter model. But we have to, as a society, begin to meet the needs of the people that we're supposed to be serving. Otherwise, we're going to continue to see the death. I mean, and I'm grateful that for a second year in a row, we've seen overdoses come down. And I could shout, you know what, because I know we give away more Narcan than anybody else in the state. I know we exchange and distribute more syringes than anyone else in the state. But, you know, I would rather be out of business. I honestly would. I'd rather be sitting on the beach somewhere, you know, looking at my internet and having a coffee. But until there isn't a need, this is where I'll be. This is the work that's been given to me because of my path. And I'm a person in long-term recovery. But I also understand that there are multiple paths. And we just have to make sure that we are able to carry people until they can reach that point.
Wow, Mark, every time I listen to you, it reaffirms I know now even more why we love you so much. So I think we have had in the last Q&A that we are having, the conversation we had was that it needs to be about political will. The reality is that no legislator, no person in the state of Connecticut um, is there who does not know personally anyone that has been impacted by this. Um, so it's not every community is equally affected, but every community is affected. So that's a reality of this whole issue. So now one of the solutions that we're talking about is this overdose prevention centers. And if I may ask any of the panelists from the first and the second to be able to bust myths that are out there about this whole thing, because we have heard them from at times from my colleagues that, oh, it's going to increase the number of users, oh, it's going to cause activities to increase, it's going to cause sale and activity. So if this is an opportunity for individuals to be able to clarify the misunderstandings about overdose prevention centers from data and beyond. So it's open-ended. You can start.
You know, I equate that to seat belts are meant to reduce the amount of harm in case of an accident. But when you put a seat belt on, when they develop seat belts, did the number of car crashes go up as a result of those seat belts? Do people feel like crashing their car once they put their seat belt on? You know, fire extinguishers are meant to reduce the amount of harm in case of a fire. But when you see a fire extinguisher, do you want to go start a fire? You know, you know. So these are other forms. I say, you know, if you were to get on a boat and that boat was going to sink, what would you ask for? You know, a life preserver. But what if the captain said, no, you know, the boat could sink? I use those as just ways of saying they're unfounded. Nowhere in any have we given out naloxone, for instance, and the numbers in that area of overdose, or people run out and inject a bundle of dope because they have naloxone or Narcan. It's unfounded, and I think it comes actually either from a place of fear or ignorance, or both.
I just want to chime in on something that I love quoting from Mark Jenkins because of the myth of enabling. And Liz had touched upon this as well. And I think I like the way Mark kind of reframes that and leans in and says, yeah, we are in the business of enabling in harm reduction. We're enabling people to stay alive. I think that has to be the new frame people need to look at.
Anyone else, please? Yes, Liz.
When we were having conversations in Canada before the injection site opened, a lot of concerns existed around, you know, this notion of congregation or an increase in people around the site that they anticipated. And there was a lot of concern, as there are here, about everything, like whether it's methadone clinic or a daycare, apparently. You know, this notion that if we put in services into communities, that somehow those are going to draw those very same issues into those communities. So one of the first studies that was done when Insight opened was about who are the people using it and where are they coming from. And it revealed that something like 98% of the people using the site lived and were regularly using within a 4-block radius of the site. So it did not have a honeypot effect. And yet this was one of those things that was heavily believed by many, many people. It was very unfortunate. The other major study that came out very quickly, I think 2 years after the site opened, was that there was visibly within the first 6 months of the site opening a 45% reduction in public open drug use on the street that was visible. So that was what eventually brought on board partners in the business community to support it. I think in any of these studies that we're looking at, and any of the data that you can access around these programs, or in any of the programs that are operating that are looked at and assumptions and beliefs are drawn and conclusions are drawn from them, it's really, really important to tease out the various social issues in the communities that these programs go into, right? So for instance, gentrification was a huge issue in the community that Insight was put into. For the first 10 years, it was the only injection site in the community, with about 7,000 injection drug users living within about an 8-block radius. So it was heavily over capacity. We had 800 to 1,000 visits a day. We had operating hours closed at 4 in the morning. We weren't funded for 24/7. That meant at 4 in the morning, people had to use on the street between 4 a.m. and 7 a.m. when we opened. So, and then as a result of the sort of changing economic landscape in that particular area, there was condo developments going on and a sort of a shrinking neighborhood, which resulted in an increase concentration of people being homeless on the street because housing options shut. And then eventually more sites were opened, all within that area and also in additional areas around the city, including in hospital emergency departments, in portables, in housing programs, because I think it's important to understand that this is not just a fixed site. This is a service, and it can exist in many different forms in many different locations. And it really is about just offering the dignity of a supervised injection to somebody who's an injection drug user, where they can ingest drugs without dying. And that can be done in many different ways in many different settings. So these giant standalone centers work. And in some ways, ours, as the gold standard for what it was meant to be at the time, was really the result of the federal government's involvement, who said, if we're going to do this as a result of this exemption, we're going to put all the bells and whistles in, and it's going to have to be, you know, it cost $1.5 million a year to run. It had, and that's the other thing, if you are going to do this, there has to be funding to do it properly, because we can't not put the services in that we're saying that we're going to do, because otherwise they're not as effective, right? So we, you know, it doesn't have, the other thing was they spent 3.8 million on research in the first 3 years, which was another part of the study. So again, when I came to New York and I saw people using the bathrooms and that was considered an injection site, part of me was like, what the heck? This is so like not okay. These are bathrooms. But then I came to understand actually that there was a certain beauty in that the people on the street that were using didn't have anywhere to go to the bathroom, and they needed a bathroom, and they needed a place to have a shower, and they needed a place to do their laundry. So the fact that they came in and had access to that, like if you look at folks using on the street, a lot of times what you see them doing when they're rummaging around with their stuff isn't actually anything to do with using, but people assume, oh, they're using, they're going in their bag, or they might be doing their makeup. They might be looking for a change of clothing. So we make all these assumptions about what we look at, and we don't actually tease out what the truth is. So I think all of these misconceptions, the land of harm reduction and the land of overdose prevention sites or supervised injection, or whatever you call them, often are riddled with these inaccurate misperceptions, is what I would say. So it's a very good question. I can talk about it for hours. There's lots of other areas where people believe things that are not true about people who use drugs just in general, and about the circumstances under which they're using. It's complicated.
Thank you, Dita.
So, and I just want to piggyback on what Liz was saying, because seeing it firsthand with Liz and John and the group that we went to over the summer in Vancouver, really a picture and a visual says 1,000 words about the compassion and the care that goes on in this place. Not to mention that Liz is a rock star when she goes there. Everybody remembers her, but it's really a lot of the same people who were working with Liz 20 years ago, because the success, I think, empowers them to be able to save lives. That empowers the people within the centers itself. But in sort of that whole stigma, Dr. Anwar, you're talking about how do we erase this stigma? And I take it back to the example of our son, Alec. He was on the road to recovery. He was doing better than ever before. We finally, after a 7-year struggle with him, felt like we could breathe because we had hope. And that day, he was living in a sober living home situation in Canaan, Connecticut. He was surrounded by Narcan. I know Dr. Heimer said earlier that overdose rates have gone down in the state because of harm reduction, and I believe that 100%. But if somebody's not there when you are overdosing to administer the Narcan, and he had roommates that were right outside of his room, but they didn't know because he was too ashamed to say. And he had a package of Narcan sitting next to him by his bedside, another one on his dresser. And nobody knew. And he was prepared. He was preparing himself. He didn't want to die. And by the way, Representative Vahey and I were sort of speaking earlier about how this crisis came about the ownership of us as a society to help people who are addicted because it's not their fault. Because a lot of it had to do with careless, man-made agenda, profiteering by big pharmaceuticals when they lied about the addictive nature of OxyContin, the Sackler family, who, after they lied about the addictive nature of their drug, over 1 million lives have been gone, including our sons, because he also started with readily available OxyContin. We have a moral obligation to keep these people alive and help them find their way to sobriety, because it happens and it can happen, but not if we are not keeping them alive. And I just want to end on this whole stigma notion. We have 4 children. One of them is no longer here, who had chronic disease, addiction. We tried for 7 years. It was just unimaginable pain watching our child trying to find solutions when healthcare protocols were severely inadequate. There were no answers. And that's why I'm so happy that Atlas came into Connecticut. So there is a directory for families like me who could find a list of reputable treatment centers. We couldn't. In the end, we failed. And we have another child who was diagnosed with type 1 diabetes. And within a month, chronic disease, we had the entire thing down. We had doctors calling us every day. We had the medications. We had everything we needed. And he is living the best life that he can, regardless of the disease. There's no difference to him. This should not be the case. Should not be the case. So we need to stop stigmatizing. We need to see this as a chronic disease, and we need to take ownership and keep our residents alive and get them the help they need.
Thank you so much. Ben.
Thank you. Yeah, I just want to speak that, the experts know, we've been knowing about these interventions for years, and the system moves slower than what the expertise shows us. So we've got opportunities where, look at Narcan access, right? When the legislation changed and we were able to expand Narcan access, now we're starting to see the benefits of that, where there is a reduction in overdose and death. So there's opportunities. When we look at what happened with the pandemic and methadone access, where for years there was rules on the books that said somebody who is seeking this life-saving medication, they have to come to the clinic every single day for at least 90 days before they can have 1 dose of their medication they can take from home. The pandemic hits and says, listen, we need to practice social distancing. If somebody's stable, give them a month's worth. If they're not stable, give them 2 weeks and let's see what happens. And people in the field were really scared because for 3 decades we're saying make this as restrictive as possible. SAMHSA just now this May changed the rules and said, listen, we don't need people to be wholly abstinent. We don't need people to be perfect in order for them to get access to care. We can do things differently. We can treat people individually and holistically. And we're seeing the positive impact to that. And that's what we need to do here too. We need to look at what the data, what the research is saying, and recognizing that there's opportunities. And when people are saying, well, this is going to create this problem, improving access to Narcan has not increased the number of people who are using opioids or overdoses. The data is showing that clearly right now. Increasing access to medication-assisted treatment has also proven that it's not going to create a problem. It's addressing something that's right there. We can't bury our heads in the sand and think that that's going to solve the problem. We've tried that for decades. It's not working.
Thank you. John?
I just want to talk about some of the myths regarding, again, some terms that you hear in this field, such as tough love. There's no such thing as tough love. They're mutually exclusive concepts. You're either tough or you're loving. And I think oftentimes it comes across as too much tough and not enough love. And there's a great book by Johan Hari, who's a friend of Liz Evans, called Chasing the Scream, where he speaks of the opposite of addiction is not sobriety. The opposite of addiction is connection. And he talks about what he learned after spending, I think, 5 years looking at what works in addiction treatment. And it isn't about confronting your loved one. He says if he knew what he knows now, he'd be holding his loved one and singing them love songs instead of confronting them and shaming them. I think we do that as a community at large. So we need to look at these terms, enabling as well. Even though I said I love Mark's idea of, yes, we're enabling people to stay alive. I also challenge the concept in general. Enabling is just an individual's understanding of showing love in that moment with the resources and choices that they have available, and that we need to be able to educate that loved one in a way that promotes their recovery and their own health, and recognize that their recovery process is independent of their loved one. So redefine a relationship in a manner that promotes recovery for all members. And don't get me started on dysfunctional families. Again, as a licensed family therapist, I want to go on record to say there's no such thing as dysfunctional families. All behavior has a function, and it's adaptive to what happened in that system. So it's our lens of humility that we need to look at a family of how did this family organize in a way that this is a reasonable choice, and not how dare we judge a family, and how dare we judge an individual. Again, going back yet to another friend of Liz Evans, her medical director, Gabor Mate, talks about he believes that all addiction is rooted in trauma. And I think if you expand the definition of trauma to look at an individual's not being comfortable in their own skin, all we want as a goal is to have them be comfortable in their own skin and be present, be able to be present. It's so hard to be able to be present when you're not comfortable in your own skin. So you have to get to a place of being more accepting and forgiving of yourself to be able to then welcome the whisper of hope of recovery. And I think that starts with those around them. And I think that starts with the harm reduction centers, giving people a safe space to have them realize they can be connected and they can have community.
Thank you for that. All those words resonate quite a bit. I know I actually had a couple questions, and I know I'll also give Rep. Claritis Dietrich a chance to chime in. And Mr. Hamilton, as you were talking earlier, you were talking about the stages of change and internal motivation versus that mandated or mom-dated. Great term. And certainly from family members who are responding in fear, in desperation, and not knowing what else they can do, as Dita has shared, not necessarily having that atlas or pathway or the map to know. And even when you're someone who is well-connected or well-resourced, it's very difficult to know where to go. But when I'm thinking about that, the stages of change in terms of an individual, I also think about that often as a social worker who familiar with Prochaska and DiClementi, that we as a legislature and we as a public also go through those same kinds of stages of change. And I think you're seeing us, move through that. Certainly the testimony last year and the visit, and I think some of us, Rep. Claritis Dietrich, Rep. Parker and I are hoping to schedule a visit into the city sometime this fall, and that we are understanding that we've got to do something differently. Also recognizing that as a committee, we're one part in this. So you were talking about, the city and the support. Again, having gone up against many of the zoning and citing conversations, I think that my interest is beyond the conversation around the science, the medicine, the practice, the experience, the depth of pain, is then taking that to that level of the stages of change for us and really looking at how do we strategize through this? And I'm thinking about that in terms of looking at communities like Bridgeport, like Hartford, like New Haven, where the problems are enormous. But because of how we are organized from a governing standpoint, those same cities are expected to shoulder the burdens and to take care of those who are struggling the most. And I represent Fairfield and Bridgeport. Um, and that is an ongoing conversation. Those of us in Fairfield, we go to the hospital in Bridgeport. And that's just part of the reality of that. So I guess not really a question necessarily, although happy to have you reflect on your perception of us. The question of political will, I get that, but I also am interested in some of those specific places that we all collectively think we could be having those conversations and where we might bring this conversation. And I think the conversation here in public health has been tremendous because putting the health lens, even in the legal conversation, we're talking about putting the health lens, but then taking the conversations to CCM, to our municipal leaders, and hearing from them, as Scott said earlier. How do we help them and say to them, we're here to help you with these issues? And I don't know if you want to reflect on that.
Absolutely. That's a great observation, by the way, with the understanding of the Prochaska Di Clementi work of recognizing that change is a process, not an event, right? And where did they come from? University of Rhode Island, looking at tobacco and smoking, because a lot of people stop smoking, but they have a hard time staying stopped. So their strategies was to tailor interventions based on that stage of change. But to your point, SAMHSA, which is, as you know, the Substance Abuse Mental Health Services Administration, years ago actually adopted a similar model, community readiness model, that we may need to tweak and tailor to look at which of the communities in Connecticut that would be most ready for intervention for harm reduction centers and be able to implement that based on kind of the implementation science. We know there's a science behind implementation. Who are the champions in the community is one of the keys in implementation science. What's their readiness? And how does that affect tailoring your message to that community? As you heard Mark said, he has the connections in Hartford and New Haven. We have the connections in Bridgeport, but it's a staging process that each community has to be met where they are as well to get that grassroots support.
Thank you for that. Senator Armour, back to you.
Thank you. So I'm just going to ask a theoretical question that, let's say there's a future group of legislators in public health, and let's say they're in 2025. I heard from Professor Burris a few things that were counter to the thought process we would have had. So the concept of a pilot is something that's been a useful way to approach it through legislations to address this issue, and then really have it a true pilot where there's data-driven information and perhaps collaboration with the university, and have that part in the picture, but also to make the process easier from the administrative side to have it from private resources funding, and be a permissive bill rather than that. But he suggested it otherwise, and I know he's not here anymore because he had to be at another meeting. But what should be the way to approach it? His approach was to do what needs to be done and move forward, because the crisis is far too big to have a very gentle approach to it. And from a legislative perspective, you want to have a legislation that is beautiful, but it has to pass. And if it's the perfect legislations do not pass from anybody, no matter who is in. So that's the part of a conversation. So I'm leaving it open-ended if anybody wants to weigh in what should be the way to approach it. I know it's a little bit of a legal and a political mixture of a question.
Can we do both?
Go ahead.
Can we do
Gita.
both? I mean,
Yes, yes,
is
yes,
it
yes.
possible to have a pilot program that's funded privately that we can enact as soon as possible, and then also move forward with legislation so that we're not delaying?
So that's and that's what we tried to do in 2023, and a lot of people have died since 2023. Perhaps we have reached a critical point for other powers in these buildings to be able to say, you know what, you're right, let's do this. But the challenge had been that while everybody is recognizing that this is the way to do this, with respect to, but they would say that because there's federal money and the state money, and then the state cannot do this against the federal law. So that's what the restrictions had been. So while we had the bill and it was beautiful, even if we passed it, it would be sitting somewhere not implemented. So that's the practicality, and so that's where the practicality comes in, that and a lot of work will have to go between now and then. Whoever is going to be, who knows who's going to be around these circles, but it's important to have enough opportunity of educating the general population and recognizing that unless we are going to intervene in a meaningful manner, we can have far more speakers around these circles without the real solution, and keep doing that. And the federal government isn't coming to fix this yet. I mean, at times I feel that they're not even having the conversations on the legislative side of the picture. So that's the frustration, if you will, as well. So go ahead, Liz, you can start and others can join.
Something that I think anecdotally might be helpful information, again, from many, many years ago, when the conversation in our community was by no means united around these sites. And really, people hadn't got much of an idea about what they were or why we would need them. And this is like back in 1997. But we had a forum in our community. We got some funding from the federal government. We called it Drugs and Crime in the Inner City. And we stuck up a giant tent and we made it free. We got music, we had free food. And it literally catered to anybody and everybody that decided to show up. Cops, nurses, community residents, strata councils.
Mm.
It was a huge event, one whole day. And we flew in folks from around the world who worked from this framework. We had somebody there from Germany who was working in a supervised consumption site. We had the chief of police from Frankfurt. We had somebody from the Swiss heroin study. We had just a range of people from Merseyside and Liverpool, and we talked all about all the different ways of thinking about harm reduction interventions that are being done internationally. And it was mind blowing for people. They had no idea, and they all left going, "Did you hear that thing? And did you?" And it was like shockingly helpful. Like it was almost like palpable, the difference it shifted people, because it wasn't like people they knew telling them what they thought so much as other people telling them things that they were like, "Hey, look at this thing." It was like a new, like it was very eye-opening and mind expanding. Nobody felt judged or criticized. It felt like very hopeful. And people went from a sort of a fixed opinion to, oh, that's something I've never heard about. That's new and different. And because it was such a cross section of people on the ground in the community, it filtered around very fast. And the impact was felt quite dramatically pretty soon. Even drug users themselves, who literally the day before had said to me, "You can't open an injection site. That's like giving candy to a baby. That'd be bad for us, you know?" And then the next day, even the users were like, "What can we do to open a site?" So there's education efforts that I think are profoundly needed across the state, that will involve, I think, multiple layers of folks just on the ground in the communities, as well as, you know, talking to decision makers at various levels of agencies and other government levels. And it can really shift. And then in terms of your larger question, I do agree with the lawyer who spoke, Scott. He said, you know, it might not be against the law to open one of these. In fact, it probably isn't, because I don't think the crack house statute was written with any intent to address a public health crisis. It was written for a completely different purpose.
Yeah.
So I think if we go into it thinking it's illegal, that's problematic for all of us. And I think that the tighter we can stick to our guns around how we articulate what the role of these centers is and how it fits within a public health frame, the stronger the state's position is going to be on defending and advocating for these as logical and evidence-based solutions to a public health emergency.
Would that be helpful, Dr. Anwar? Sorry to interrupt, but would that be helpful to shift that perception of the federal law obstacle that the state might be afraid of, if we were to take that legal viewpoint that was pointed out earlier, that we aren't actually breaking any federal laws?
Oh, it's worthwhile to test it for sure, and then because otherwise there's not enough private money to be able to do anything meaningful with the disaster we are facing right now. And so it's worth a trial. And again, just me speaking. So it'll require an entire body and others to weigh in as well. So, John, you had a comment, or sorry, Ben?
Thank you. Yeah, I was just thinking about a lot of what was being said here. And, you know, the stages of change metaphor, I think, is totally applicable. It's our jobs, I think, as providers and community members and caregivers and just representatives to continue to get the message out and to address the fact that if we're going to move people across the stage of change, we need to address the stigma. We need to look at some of those things. I think, Mark, you said it eloquently, you know, the terminology in which we use will definitely help us in this process. Is what's more palpable, safe injection sites or overdose prevention? For me, I think you're going to get a bigger audience or more people buying in by using terminology like overdose prevention. And then to Liz's point, to the legality of it, you know, we're not supplying the drugs. We're not supplying anything that's going to do anybody harm. We're actually trying to save harm. And in our programs now, patients come in and they have contraband or illicit substances, and there's a system and there's a process for managing that. So how hard is it for us to be able to shift this in some ways? Again, it's the idea of, hey, if I turn a blind eye, then I'm not responsible for it. But we see it now. It comes into our facilities all the time, and we can manage it effectively if we are allowed to do so.
Go ahead. And John wants to ask after that.
I just want to respond to that because obviously I take a social worker lens to this work, but denial is a powerful survival tool for individuals and for communities alike. And we do this all the time. We want to pretend that this isn't happening. And in many ways, in some communities, it's easier to make things be invisible. And so part of this work, as I see it, is to bring visibility, which is what today is. And I'm grateful for that. That's what we had through the public hearing process. But it's also being very strategic in how and where we bring the visibility. And I think from the legal standpoint, in terms of looking at this, we've got to talk with our judicial branch partners. And we've got to see what kind of willingness we have in a partnership. When I go to the third grade classrooms, I talk all the time about the branches of government. We have the executive branch and the legislative branch, and the judicial branch is there when we don't necessarily agree on how things are being interpreted, right? The law, clearly, today we heard from one attorney, but we have a Supreme Court here in Connecticut and in the United States because there are differences of opinion about how laws are interpreted. And certainly for us here in Connecticut, you know, I did lean over and talk to Dita and say, I'm thinking a lot about the Sacklers today, about being from Connecticut, from Fairfield County, Connecticut, no less, in a state that benefited. We benefited. Don't we have even more of a responsibility then to then address this? And it's hard not to have a tremendous amount of emotion. And Senator Anwar and Rep. Claritas Ditria know I try and keep it even here, but the outrage and to think about the pain Vida and her family and 1 million other families have gone through, it's unconscionable. So yes, we have to explore every strategy. We have to take that emotion, as all of you do every day, and channel that into, you know, how do we have these conversations very strategically and thoughtfully so that we're successful in this. Thank you for indulging me with my passion there.
Thank you, John.
Yeah, I just want to echo the support of what both Mark and Ben had mentioned about language mattering. Language does matter. So we know that safe injection is a lightning rod term. It's a polarizing mindset. So why aren't we looking at language and have it be more benign in a way that can meet the communities where they're at? You know, again, the action stage for an individual is the same as the action stage and the change stages of change for a community, is that the person sees there's a problem. It's literally killing people, and now we have to do whatever it takes. I'm a big fan of CCAR, Connecticut Communities of Addiction Recovery. They're a leader internationally and nationally in the recovery coach movement and drop-in centers. I've been on their board for years. I think they do a wonderful job. They set up these recovery centers around the state as drop-in centers for that 1 out of 10 people that are ready for recovery. Why don't we set up drop-in centers? And we need to come up with a new term. It's a harm reduction center, low barrier care, but just a safe space for a drop-in center for people that are still using substances, equivalent to CCAR. Then we have to also tailor some of the language, because recovery coaching is another wonderful asset for people to have a partner in their recovery journey and help them navigate that. But we really don't have too many harm reduction recovery coaches. So maybe we need something more like a life coach, or another term that we can use to give them companionship and support in the community and make that engagement. But I would make a suggestion to actually phase in low barrier care in a harm reduction drop-in center with an implementation 6 months and 12 months out, to then consider having the safe injection be just one component of it, if it's going to be the hard sell and all or nothing. But why not open up these safe spaces for individuals that probably wouldn't be welcome or feel welcome at a CCAR recovery drop-in center? And we know they're out there and they deserve community and connection and services and support as well.
Yes, Mark. Thank you.
In 2018, we opened up the state's first harm reduction drop-in center in an area where, actually, if you look at some of the numbers that were coming out, was in the area that it was warranted. But again, being from that neighborhood, knowing what was happening, and even around that particular building, and being able to get space, we saw in an 1,100 square foot space, we opened up with under $50,000 in funding, a combination of sources. And in our first 10 months, we had 18,000 visits from 684 unique participants. And those numbers continued to go up until actually when COVID hit. And even when COVID hit, we never closed our doors. We just actually switched over, or I should say adapted to one person at a time in that space. But the need never went away. And we actually saw, and even see now, we can look at the numbers where the instance of overdose in that area of fatalities dropped. And also the instances, even like where our mobile units are, our mobile MAT, but yet and still public, I won't even say public will, because there's a thing with, if the right person speaks out in the community to the establishment, they can move things. And so as a result of that, like our RV was moved from a very needed position farther down Weathersfield Avenue, because it was said again that because we were there, that kept that element present. Well, that element was present prior to us arriving, because that's why we went there, because of need. And since then, and it's been over almost 2 years now, that element still exists there, but our numbers went down, because people, if you move something 1 or 2 blocks for the left to the right, they don't look for those services, and they continue on. And so there's a lot of other things that there's a lot. We say people don't always enter the doors through traditional means for treatment, for healthcare services. You have to put it in that path, in their path, and sometimes even incentivize them. I don't know how I ended up taking this left turn. I think I'm like, John always comes with a Trojan horse. So I was trying to figure out where where that was. But I have to agree. We got actually the harm reduction centers, as a result of some of the language that was going on as a pilot. That's where I was at. I don't know how I got, forgive me. Similarly, could we do something, a larger pilot, but access OSAC funds? Those are not subject to the same rules and regulations as the federal funds. And it's a matter, if it came from this body or, a legislative body, like wanting this, it's not a hard lift. It's not a hard lift whatsoever.
Very helpful, Dita.
So just on the concept of what John was talking about, the language matters and safe injection is a trigger for folks. It just got me thinking about the fact that when we were in Vancouver, we realized that the trend for people whose illicit substances has moved away from actually injection and more smoking because of vein exhaustion and other reasons. And Mark, I don't know if you're seeing this and if we're starting to see this, but we did talk about the fact that often what we see in Canada, then it kind of comes here, and it's something to be cognizant of, that safe injection facility may not even be an appropriate name just because the majority of users may move away from that method of injecting. The other point I wanted to make is in terms of the fear that's out there that somehow we are enabling, we are propagating the use of drugs. Again, I'm going to take it back to Portugal, where in 7 years they reduced their heroin overdose rates by 90%. And when I was there, we talked a lot about why they barely have a problem at all anymore. It did not propagate more use. It took away the use. And in fact, fentanyl never even came into their country. So they are such a model, and population wise, not that different to Connecticut in terms of scalability, because I spoke to them about scalability. But they're such a model to the extent that, I know that Dr. Gulau, who's a drug czar there, he spoke in Rhode Island, actually, maybe last year, a couple of years ago. Seeing and hearing makes such a big difference. And it might be something that we want to consider, where we invite someone like him to talk about that story, that success story, and how we can replicate it.
Sorry.
No, thank you, Senator Anwar. I just want to go back to what Mark was saying about the OSAC, the Opioid Settlement Advisory Committee, and the funds available from the settlements, the legal settlements. And certainly cognizant of what we did wrong with the tobacco trust fund situation and still haven't gotten right. I think that the process of having that municipal and legislative and stakeholder input, it's helpful to have the multiple stakeholders around the table. I know it's still an evolving process, but just naming that, we now sit as members, as co-chairs and leaders actually on this committee. But, we've had some conversation here about what we do legislatively versus the process that's been set up. So I'm just naming that as kind of a sensitivity, but I have also had the same thought as you in terms of, access to funding. This is the idea, to use these funds to save lives. So just naming that. Thanks.
So what should we name these sites? One line from the panelists over here. And I know, Thaddeus, you're there too listening. So if you have one name for what these sites should be, safe injection site is not it. Harm reduction is there already. So go ahead.
I'm in favor of overdose prevention. I think that kind of speaks to what the goal is, to save lives. And I think it's a little less stigmatizing, and it's clear what the intention might be.
I would go with drop-in centers. Just to expand on the model that Mark has tremendous success with, we're going to do a lot more than overdose prevention. We're going to create a safe haven for individuals looking for other services as well. So I think that becomes something that's pretty benign and hopefully more accepting in communities.
Drop-in centers?
Drop-in center.
Yeah, I think the less attention you bring to it, the better. I mean, I really do. I know even, when the talk of, when the first round of these harm reduction centers came out, I was really glad, that the that piece didn't make it into this, only because, and I think I said this to a few others, if any type of the injection piece would have come at that time without favorable will at a larger level, I know what my life would have been like, because I would, at that point, I would have had a bullseye, on my back, which is large enough as it is. I don't need anything else. So, but yeah, I think it's one of those, when the path of least resistance.
Thaddeus, do you want to weigh in on some of the things and also the title you wanted to suggest if you had a thought?
I'd agree with drop-in centers. It's a whole, a more holistic approach to everything, and I agree with what has been said of keeping it away from harm reduction, keeping it away from safe injection, because it is a much bigger, greater thing going on, and the services provided are comprehensive in drop-in center. I like that name.
Anyone else? Yeah, go ahead.
Yeah, I just, I guess, second, third, what's been said about drop-in centers. I think that it acknowledges the ecosystem that we create and the many parts of it, not just the worst possible outcome, which is an overdose and a fatal one.
I also want to point out too that we have these great vans, as Mark does as well, out in the community. We got these psychedelic vans. It's peace, love, and liberation. Some people look like they might be picking up psychedelics in it, but that said, even the Undersecretary of SAMHSA loves that as a model and wants to see that everywhere. It's something that's so welcoming, and that's a safe space on four wheels. All we're doing is expanding that safe space on four wheels. There's no, we give out, safe use kits there, but we don't put on the side of the van, get your crack pipes here, because that might get some pushback in the community. But what do we give out, Liz? Crack pipes for some individuals, because that's meeting them where they are. So it is so much about messaging and language, and just a welcoming, receptive, kind of like benign drop-in center. Yeah, I think that there's so much we can do. We could just we can call ours Liberation Drop-in Center, because we have so many services and it can mean different things to different people, and we'll meet them all where they're at.
I just have a question on the drop-in center. I love the idea, but I'm just wondering if it would be descriptive enough for someone who really needed to use that center to know that it's a safe place to use their drug of choice. Like, I'm wondering if it should be overdose prevention drop-in center.
I'll push back right there, because our people speak and pass word quicker than any internet service could. And it's the individuals that we're trying to reach. And again, you start to get this amongst the service providers. And again, when I say the path of least resistance, and that resistance comes from, Joe and Mary Public. So we're trying to reach those, I think, that need it. I don't, like, for real, we can do it all day long. I don't even have to put a sign up. The people that I need to serve, I'm going to be able to reach them without ever putting a name of anything on the front of the building.
But Mark, and I completely agree. You have a way of reaching people like nobody else does, and obviously, with our vans at Lib House, but as we know that this disease cuts through many circles, many demographics, and so I'm thinking about healthcare workers or corporate America, or that type, that demographic where this disease is also quite prevalent, if we are going to be able to reach sort of every demographic.
I would add to that too. I agree with what Mark said. I think that the word on the street will spread quickly, but I'm also concerned about becoming too benign, so that we're actually reinforcing some of the stigma yet again by saying, listen, this is bad. This is, we don't even say the word because we're fearful of what people will respond to. So I think it's trying to strike the medium. So I think, harm reduction or drop-in center sounds great. I'm also still, thinking we shouldn't hide too much what our real intentions are, because then we're just feeding into the stigma. Like there's something wrong with somebody who's having this issue, and that's not the case at all. This is a larger issue. So it's going to be hard to navigate it.
So we've been here for about almost 2.5 hours, and then we could probably go on for much longer if we could. This has been a very important conversation. We have to have conversations like this. Um, Status quo is not acceptable. We have been moving in the right direction in some respects, but not necessarily walking through the door that we really need to. And for the families and the individuals who are hearing our conversation, this is in your honor, and the ones that are no longer here, we owe it to the people who are going through some challenges that we fix this as a state, and we can value each life and value every person and meet them where they are. And this is part of that conversation, and this is going to be one of the conversations. We'll continue to work on in this direction. This is much needed. Even one life lost is too many, and we have to walk into and have as many uncomfortable conversations as we have to, if people are uncomfortable with them, till they get comfortable with these. And we would not be able to do this without the expertise, the passion, the commitment, the experience that all the panelists have brought together, because you are the ones who have experienced this. You're the ones who have been able to help people, and you understand what is at stake. We wanted to thank all the agencies who have been listening in online and in person, because we will be knocking at your doors about how you're going to be able to help us out going forward. So just because you did not get to speak today, you will be hearing from us sooner or later about this. And finally, the Public Health Committee members who have been listening in, my co-chair, who's been a partner and huge support in this effort, and all the other members who have joined in, and Representative Claire Desditra is here as well. She's been very focused on making sure that we do all the right things to help our citizens in our state. So we have all the right ingredients in our state. It's just now moving in the direction and moving forward with this. So I will stop over here, and I'll give the last word to my co-chair.
Just thank you, and stay hopeful, stay committed. We're with you, and we're going to work together and continue to work with you as you work to save people's lives. Thank you.
We are adjourned.